Welcome to the pitch competition. This is a feature of this symposium that we do every year, and so this is the 4th year we're doing it, and it's always, very fun. It sort of showcases the kinds of things that we do here, the types of awardees that have won these awards. So let me give you a little bit of background. My name is Phillip Phan. I'm one of the co-PIs of the AITC. Together with my colleagues, we'd like to welcome you again to the Bloomberg Center and to this year's A2 Symposium. We have with us today 3 very distinguished individuals that have agreed to donate their time and their expertise to judge the pitches, the competition. Mike Hughes is Vice President of Strategic Growth and Partnership at Leading Edge, Washington, D.C. Leading Edge is a trade association representing over 5,000 nonprofit senior living communities and aging service providers around the country, right? So they are, if you will, at the front edge of the long-term care community and business model. Soo Jeon is head of HealthWorks Accelerator. HealthWorks Accelerator is a part of the Blue Cross Blue Shield family network, and this was created not too long ago and highly successful arm of Blue Cross Blue Shield to accelerate and to encourage innovation that supports their members. And so we see more and more payers interested in bending the cost curve so that the resources that are being put to healthcare are better spent, better used, results in less waste, and reaches more of their member communities. And so this is a really good example of some of the innovations that is happening in the payer space as well. And of course, Soo Jeon, being head of the accelerator, is very used to seeing these kinds of pitches. They do their own pitch competition, so she's good. And then finally, we have Rick Robinson, who is Vice President and General Manager of AgeTech Collaborative from AARP. Some of you were at the AARP reception on Wednesday evening, and AARP, which is the largest representative group of older adults in the United States, has an accelerator, again in the spirit of accelerating and encouraging cutting-edge innovations to help older adults. So they will be judging for us. Each of them will have a score sheet that they will complete as they listen to the pitches. Today we have 6 pitches. These 6 finalists were selected from a field of about 60 plus awardees from the Year 4 and Year 5 cohort groups. Let me give you a bit of context. I think in the first day you heard from Rose that we have, as the 3 AITCs combined, received more than 1,500 plus applications. To date, we've funded about 150 plus pilot projects and startups. So, you're looking at a very small hit ratio, right? So these are truly the creme de la creme of the applications that come from us basically across the whole country. And so these 6 finalists were selected using the same rubric that are going to be used today for judging the competition by a committee from the AgeTech Collaborative, AITCs, as well as the AARP AgeTech Collaborative. So again, this is a subset of a subset, a very, very distinguished group. They're here to highlight the kinds of things that we do, the best representations of what we fund at the AITC Collaborative. The winners will be announced at 3:20 p.m., so make sure you come back by 3:20, where we would have completed the scoring and the tallying of the results. Each winner will receive $3,000. It's a token award, but I think the most important thing is that they won in a very, very tough competition. I would also like to say that for those awardees that were not selected to be finalists, I don't want to sound like a kindergarten teacher, but you are already a winner, right? I mean, you got your ribbon. You are 1 in 10, 1 in 12, depending on the year. So that's sort of like an R01, depending on which institute you apply to. So this is already, I think, a very, very high achievement for you, and you should you should think about this. I hope that it would motivate your work and that you would be looking for the next stage of success as you prosecute your research and development program. And then finally, I want to acknowledge the sponsors of this competition. BioHealth Innovation is a consultancy for startups in the healthcare space, and they actually provided guidance and consultation and advice to the submitters of the pitch competition. Also support from the RRF Foundation and for Aging and the Gerontological Society of America. So all of these organizations, of course, send their congratulations, and we'd like to thank them for their support. What will happen is that the pitch competitors know the sequence. They will each come up. They have 5 minutes. They will be cut off at 5 minutes. That's my only job here. And I've told them, don't let me cut you off. Doesn't look very good, all right? And then after that, we will go, for the lunch break, and then come back again at 3:20 for the announcement, all right? So without further ado, may I ask for the first?
Hi, my name is Nancy Hodgson, and I'm a nurse researcher at the University of Pennsylvania. When we started off yesterday, we heard from Mary Lazar about the caregiver crisis that we have in the United States. I'm a nurse and a nurse researcher. I've observed caregivers navigating this complex crises that they face in trying to find help. I'd like to begin by introducing you to Grace Chen. She's a caregiver in West Philadelphia caring for her mother, Linda. Grace is also managing 2 children, managing a full-time job, and trying to navigate the complex care for her mother. She's been feeling increasingly burdened and having a tough time on the crisis point of feeling burnt out. She's not alone. She's one of 11 million caregivers in the United States who provide 16 billion hours annually on average. Why is this important? Because when caregivers are feeling impaired, their loved ones feel impaired, and this is associated with poor outcomes. Caregivers of individuals with dementia are at higher risk for chronic diseases, also depression and anxiety, and when they're impaired, their loved one is at risk for higher risk of poor outcomes, which is associated with $600 billion in care to our annual budget. Our solution is offload. This is the picture of our platform. This is a screenshot of our platform that you can sort of see the features of. This platform is a voice recognition technology that has been analyzing by listening in the background to care coordination team meetings with permission. And it's been listening to and Grace's voice in the care coordination team meetings and observing Grace's stress in her voice. It's alerted Grace and her care team to the last time that Grace was attending the meeting and finding that there's a stress level now increasingly alerting them to a risk for burnout. This is the only system that would be in this space. We have no way of identifying caregivers that we've heard about throughout the meeting and no way of identifying burden. So this is a proactive system for identifying burden in caregivers and the only system of its kind. One important feature of it is a dashboard that also helps the care team proactively address Grace's burden. So when she attends the next meeting with her mother, the care team can address the burden. This is through the chaplain recommending a support group, the care team adding days to for her mother to attend the care center, and for other supports to be provided to Grace. So again, proactively addressing Grace's burden. We developed this system by recording the voices of caregivers across 10 PACE programs in the United States. So we had a diverse group of voices representing all types of caregivers across the US, and we measured caregiver burden using gold standard measures of burden. So this is grounded in evidence to develop our algorithms. And that's what we've been testing throughout this pilot. $42 billion represents the total market, and $3 billion is the digital market and care coordination. So 10% of that is what we're feeling is an addressable goal that we can reach, or 300 million. There is, again, nothing in this space, but we feel like this is a unique opportunity that offload could be tagged onto in terms of EHR. Point-click care is the EHR for long-term care and post-acute care. So something like offload could be an added value to EHR systems. And we know that caregivers are addressed in traditional care planning, so this is something that would be helpful for added value for care planning. We have the traction that we've shown the proof of principle in this pilot study. We've been awarded these $200,000 in this pilot study. We have a great relationship with our advisory board. We've partnered with Trinity Health PACE, the largest PACE provider in the country, and VNS Health, which is the largest home health care agency in the country. They're a member of our advisory board, and they've been telling us that they are interested in continuing to partner with us. They've been a member of our end user group, so they have given us the important end user feedback from the very beginning about its usability, how it fits within workflow. Our team is the best in the country. We have international experts in dementia caregiving and in AI and NLP. And our vision is that we hope you'll partner with us so we can shine a light on these important caregivers. Thank you.
Great presentation. Thank you for that. Question. The only time you capture the voice of, I forget her name, Linda, let's say, that's you.
Great.
Is during these group sessions, or are there other times where you're capturing the voice?
There could be other opportunities. In this particular example, they've been captured during Grace's attendance with her mother to the interdisciplinary team meetings. So that would be how we would work it through in the PACE program model. We see other opportunities to capture it. Ambient listening is increasingly becoming something that's happening in primary care, and at the University of Penn healthcare system, we see it more and more. But when we developed this, it was with the PACE model in mind, and that's where we have one model for its application.
Is it working? Oh, hi. I agree. Terrific presentation. And I'm thinking about kind of like the integration into workflow here. So the intent would be that this would be sort of a module that would be included in a point-click care or another type of care. And is there an ambition to kind of close the loop and provide kind of a data loop in with the actual intervention that's done, and then reevaluating that caregiver for efficacy to basically measure the reduced stress load? We recognize that somebody is stressed, this caregiver could use an intervention. The intervention is then delivered, and then is there then a follow-up?
Well, there would be continuing monitoring, I guess, through the voice is continuing to monitor in the other meetings, following up, so it could capture whether or not there's a reduced signal in her stress level. So that'd be one way of capturing that feedback. We would also be tracking whether or not the action items were accomplished, so whether or not the team has followed through with the items that have been recommended. Thank you.
Good morning. We are Health Equity. We're a digital twin platform to optimize the health span. We're a team of 4 founders who have lots of experience in healthcare, technology development, and commercial and defense spaces and research. I'm Kathy Kim, I'm the CEO. I'm a health informaticist with many years of experience operating in hospitals and medical groups. And my last venture-funded startup was acquired by Oracle. My co-founder is here, Vinay Pai is our Chief Technology Officer. He's an engineer. He was a program officer and scientist at NIH and helped found the Digital Health Center of Excellence at the FDA. We're backed by a world-class advisory board that is really active with us, including doctors and nurses, gerontologists, and AI innovators. In the last generation, the goal of healthcare was to enhance longevity. That's the lifespan, or the years of life, and we were successful, 73 years. But now we need to optimize the health span, which are the years in good health free of chronic disease or disability. The problem is there's a gap between lifespan and health span, and it's about 9.5 years. So healthcare needs to bend the cost curve, especially among the trillion-dollar chronic diseases anchored by diabetes and cardiovascular disease. We need to reduce the time to deliver optimal and personalized treatments so our dollars go to the best impact. And individuals need personalized care plans that guide what they do, not just at healthcare visits, but also in the moment of their everyday lives. The customer problem, though, is this. If you have diabetes, there's 1,000 practice guidelines for diabetes, 7 major diabetes subtypes, and by moment, every individual is changing. We monitor 13 key clinical and lab characteristics, biometrics to see what our bodies are doing, and patient observations. Combine that, you've got millions of combinations and trajectories. So what do we do to make decisions? And this is where health tech digital twin comes in. We're a National Academies compliant digital twin that mirrors the healthcare and patient journeys with a generative simulation and prediction engine that's driven by real world data to improve the time to impact and the cost for effectiveness. So how do we do that? Well, we can screen based on hundreds of protocols, evidence-based guidelines, and your experience to find the scenarios that will work for your patients. So you find groups that are most like me or most like my group. You can actually identify those interventions that had the best outcome and simulate how that might work in your own group or in your own life. And then you can rapidly try that intervention and refine how it's going as you bring in real-world data from wearables, EHR, or patient-reported outcomes. So you're updating the model, but you're also updating how you're delivering that intervention. And then we add on top of that trustworthiness metrics, which allow us to give you confidence in the predictions that are being given. So of course there is competition. There are AI digital twin platforms for chronic care management, and you see some of the major competitors there. But there are 3 things that really differentiate us that none of the other competitors have. We have a proprietary ensemble AI model that includes agentic AI, large language models, and traditional machine learning. We have validated our simulations on large population data sets, 3 of them across the US and EU. And we have developed these trust metrics, which are verification and validation, uncertainty quantifications. And these 3 things combined are the requirements that National Academy said need to be in a health digital twin. There's a large opportunity for digital twins. The global market is $60 billion. In the US, our TAM is $4.5 billion and growing rapidly. Our SAM is the personalized medicine segment of digital twins, which in the US is $1 billion. And our SOM is 10% of that market, which is $100 million, starting with a beachhead in research and academia and the healthcare provider target segments. Our business model is to go for that beachhead, researchers and academics in US academic and large hospitals and commercial research organizations, focusing on $2 trillion chronic illnesses, diabetes and hypertension, and then expanding geographically and by condition, and then expanding customer segment to pharma and biopharma. Our revenue model is an annual SaaS subscription fee scaling with the size of the implementation. We have a substantial amount of traction since we spun off from MITRE and UC Berkeley in April of 2024 with a care coordination and remote patient monitoring system, which is now in the market. And we've built our digital twin using data from that care coordination platform. We have several research partners, including UC Berkeley and University of Minnesota, as well as clinic customers, and a toehold in Germany with a research partner and a market development partner. So we're already addressing the customers that we think are our beachhead. We have $750,000 in revenue, including clinic revenues as well as grants, and we've won several pitch challenge competitions both here and in Germany. We're leveraging SBIR and other federal funds for R&D, and we're raising a seed round of $2 million for the next year and a half. Thank you.
Thank you. Judges, questions?
I always have questions. Congratulations, great pitch. Outcomes. What sort of outcomes are you seeing in disease state?
Yeah, so what we track our clinical outcomes such as hemoglobin A1C, blood pressure control, as well as quality of life outcomes for patient-reported outcomes. We track all of those things. In our pilot implementations, we've been able to improve hemoglobin A1C by an average of 3.7 points within 6 months, and systolic blood pressure by an average of 19.5 points within 6 months. So that's really at the beginning stages. What you have to do is sustain that over the long term, right? The trajectory is the whole life. So we need to keep going so that we can maintain those kinds of outcomes.
I'm going to tag one more on to this. Sorry to be selfish, guys. But to what degree is your ambition around patient-facing for something like this? It seems like more knowledge is power, and with that comes adherence, right?
Yes. Yeah, I think that the initial product is really around population and scenario planning, so you can decide what kind of interventions do you want to invest in. Eventually, we want to get to that individual level. So if you go see our demo, you'll actually see individual level results using our digital twin, because we'd like to provide that to the individual participants, because they're the ones deciding moment by moment what they're going to do. So you need the collaboration of both the clinical providers as well as the individuals to have the same information. So our ambition is to do both.
No more questions? Thank you.
Thank you.
Next.
Good morning, everyone. I'm Nili Solomonov. I'm a clinical psychologist and a researcher at the Weill Cornell Institute of Geriatric Psychiatry. I specialize in leveraging novel methods to improve the well-being and mental health of older adults. Here, we're leveraging and empowering human-to-human interactions with AI through social cue, which is a brief conversation that matches older adult to the right kind of support. My co-PI, Logan Grosenick, has complementary AI skills, and we're joined by an advisory board of experts in nursing, geriatrics, AI, and public health. Social disconnection is a major public crisis of our time. Yet most current approaches rely on self-reports. These are subjective, they are impacted by recall bias, they're imprecise, especially in aging, and as a result, many older adults get overlooked or mismatched to services. We're proposing a need-based market that would be a unique value-based proposition to develop a personalized and objective measure and intervention for social disconnection. Not all social disconnection is the same, and that's why subtyping matters. Here you can see data from our A2 pilot over here, and what you see is that many individuals have different profiles. We're able to capture these profiles through subtyping. For example, we can have an older adult who's emotionally unsupported but has a large social network. We can also have an individual with small network but has high motivation to engage socially. A third person may have recent interpersonal losses and mobility problems. These older adults require different strategies and interventions. Without objective measurements, time and intervention dollars are wasted. We propose a social cue turns a brief conversation into a personalized, actionable care pathway. Through a conversation that's on a video platform, older adults interact with either a clinician or a caregiver. We analyze rich behavioral data, including language, vocal prosody, facial expression measured simultaneously, and identify a distinct profile of an older adult. Based on these profiles, we offer guidance, personalized recommendations, and strategies to care. The result is an objective report that you can act on immediately. An objective measurement that's precise and steers clear from guesswork, subtyping of a unique profile of the older adult, and a match the next best action.
Our initial wedge is community-based aging services, especially senior centers, core giving organizations, and community aging organizations in New York City. In these settings, assessments are already happening, and better triage can improve service matching right away, yielding ROI. After this, we can expand into health systems, geriatric care, and value-based care partnerships. The total addressable market in the US is 61 million adults, more or less, over 65 plus. In New York City, this is 1.4 million, and we'll initially target 50 senior sites out of about 1,000 citywide. We've shown feasibility through our A2-supported pilot work. We've built the social cue assessment pipeline, obtained IRB approval, trained our staff, collected data from 66 participants, and clustered for the first time to find strong evidence of measurable subtypes of social disconnection. In terms of customer acquisition and retention, we have a robust pipeline, having recruited more than 4,000 older adults previously and having an ongoing collaboration with community aging service partners, including 23 senior centers in New York City. Our pilot design reflects real-world conditions with modest caregiver burden, and we're now further validating subtypes, engagement, and recommendation outcomes. Our business model matches our wedge. In phase 1, we use site-based subscription pricing at $6,000 to $18,000 per site per year. That makes adoption feasible for community organizations and care settings in New York City. In phase 2, we'll expand to enterprise models of health systems and Medicare Advantage with ROI driven by better matching to recommendations, less wasted time, and objective proof of impact. Social Cue is differentiated from existing models in 4 ways. It uses objective multimodal behavioral AI. It provides actionable subtypes into social types. It supports scalable real-world deployment, and it offers next best action recommendations. In other words, it goes beyond subjective self-report and risk scoring to help organizations objectively act on what they learn. Our mission is to transform late-life social disconnection assessment from subjective guesswork to objective measurement and personalized support. We're pre-revenue and running on the AI pre-seed, our institutional funding, not yet fundraising. We both have extensive experience subtyping. Nili has established partnerships with NYC Department for Aging and expertise in large-scale clinical assessments and interventions in late life. So she's the clinical lead. I'm the AI lead with deep experience in multimodal AI for subtyping, and as the AI editor of JAMA Psychiatry, regular insight into current research. I've also co-founded a revenue-positive wealth tech company previously, where we focus on next best actions and advice for advisors and have $10 billion under management. And we're advised by respective leaders in geriatric medicine, nursing, and AI for population health. Thank you. We'd love to take questions.
Thank you.
Sure. Thank you. How often will you be evaluating the subtypings?
That's a great question. So we're now operating within NYC senior centers where older adults are getting evaluated regularly, initially when they register, and then later on, over time, every 3 months is the requirement. So we're training our data on longitudinal measurement, and part of our goal is to identify what is the right lag, how many times, can we do this just at a one-time point without any additional follow-up. But the idea is that you can do this within 10 minutes with your phone, on video. You can hand the older adult the phone, and you can do this as many times as you would like without it being a significant burden added or additional technology needed.
So the older adult has to come to one of the community centers?
Well, they can do this from their home.
They can.
We're training this on community real-world data on older adults that are aging and integrated within the community, but we are thinking about applications later on.
But leveraging existing video-based teleconferencing.
So there's not a requirement that for someone to go somewhere, they can do it from their home, or they will.
No, and we've trained this also with older adults who are just at home, and we've never seen them, and we've only ever just said, hey, do you want to do this? And they live in other states, and we never actually meet them.
Yeah, and is the strong value here really around workflow efficiency? Is the idea that, current state would be an in-person type of interaction where someone would sort of just do this. And we do this a lot in our communities, you might expect, especially around pastoral care, which is very intuitive in terms of how you look at someone and kind of categorize someone and things like that. With something like this, I would imagine that if you were to sort of give that counselor or pastor a head start, and essentially say that we believe this person kind of fits within these types of situations, and that's the workflow efficiency right there, right? So now you can spend more time doing this instead of kind of just trying to figure out where somebody is as a starting point.
And you can quantify it, right? There's not really otherwise objective measurements of how well you're doing, where this person is in terms of their social disconnection.
And that's my next question. Really, is how from my previous question, the earlier pitch. How are you measuring efficacy?
Yeah, that's a great question. So I think to your first question, we are really thinking about leveraging what is readily available and free. Humans interacting with each other, right? With this whole development in robot interacted with older adults, we're really thinking, let's go back to basics. people do this all the time. How can we quantify this without actually asking them, are you socially isolated? And they say yes, right? We have the technology, we have the measurement, we can do this, and it's a signal. And it's something that is really easily digestible to an older adult. We all want to feel socially connected. It's not something that's wrong about you, or that you're sick, or that you have dementia, or it's not a sickness model, it's a wellness model. And then with that signal, we can measure other things later. And we do have in our training set measures of depression, of cognition, of quality of life, of what we think is behavioral activation, activity levels. We have training of passive, we have many, many measures. Part of our work is dimension reductionality. Can we identify the one or two things that are markers of social disconnection and move with these? Really simple.
I might have missed it, but is part of your solution to offer a kind of virtual persona that they could engage with after testing?
We're not, this would be more like this could match you to whether or not that's a good, like if you have a social type that actually really needs interpersonal interaction, that would be different than a social type that might react well to an LLM, right? And you'd want to know which type it is. So this has worked very well for us in depression and other domains where there's different types of depression, and which type you are dictates which treatment works. Here we're saying what sort of positive recommendations can you make based off of what social disconnection subtype you are.
Based on what exists in the real world, right? So we would say, hey, these 3 community activities would be work for you. You should do more exercise. Let's focus on remote activities because you have mobility issues. So the personalized recommendations would be ways to develop social connectedness that are readily available within your environment. That would be a generative piece, but it wouldn't recommend generative AI, if that makes sense.
And if you're a senior center with 3 possible things you could have someone doing, you might want to know which is best for which.
All right, thank you.
Thank you.
Great job. Thanks.
Test. All right. Hi, everyone. My name is Junjun Chen, CEO and founder of Rekinesis and Mobility Lab in your shoes. So as a volunteer EMT, I see this almost every week. Over 60% of 911 calls that I respond to involving older adults are often due to falls or mobility problems. And these emergencies don't happen suddenly. They are the result of months of silent gait deterioration that no one measured. And mobility decline can affect anyone, but older adults are especially vulnerable. And the problem is getting worse. So in the US alone, there are 35 million older adults living with mobility problems, costing over $50 billion every year. And there is a large unmet need for early mobility monitoring. So today, mobility assessments live on 3 separate islands. So gait analysis lab, they are accurate, but they are expensive and stuck in the clinic. And wearables, they are simple, but they only provide shallow insights. And pressure insoles, they only measure pressures, and they don't give full biomechanics. So that's why we developed Rekinesis, which is a wearable sensing platform that captures high-speed, high-resolution pressure, 2D pressure data, and use AI to reconstruct full AI mobility from real life. So we keep it real simple for the clinicians. So instead of a raw data, they get a Rekinesis score that track and rate their mobility and over time, and also they get key metrics such as stride symmetry and ankle range of motion, and with a clear trends compare week from week. And most importantly, they get full remote mobility monitoring. And this is all from real-world walk-in, not a short clinic visit. So Rekinesis is the only platform that delivers high accuracy, continuous monitoring, and low cost. So the current clinical assessment relies on the clinician eyeballing the patient, which can be subjective, and also it can be slow. And also, those gait lab assessments is really expensive. Also, a lot of times require our older adults to travel to specialized centers, and that can be very inconvenient. And oftentimes, the report can be inactionable and even frustrating to our providers. So we make the workflow real simple. So the reconnaissance, the user, the older adults, they wear the sensors in their everyday shoes and in their everyday life. And with our algorithm, we are able to generate a comprehensive mobility report that will enable insightful clinical actions. And we have validated the technologies in a preliminary study on 15 subjects. So you can see the solid line is the gold standard motion capture data from the GATE lab, and our dashed line is our reconstructed mobility data, the motion capture data from pressure only. And so we are able to reproduce the hip, knee, ankle angles just from our high density, high speed pressure data. So we have made some early traction. So we have tested 15 subjects, and we are expanding to 75 subjects in AITC pilots, and also interview 30 stakeholders, and we'll plan 100 stakeholders in the national I-Corps, and we also have 3 clinical sites ready for pilot deployment, and we have multiple funding pathways in preparation. So the market opportunity is huge, and we have early adopters, $500 million in the rehab clinics. Also, we can expand to $112 billion US outpatient home-based mobility assessment, and the global market is $50 billion. So Reconnaissance supports reimbursed mobility assessment. The providers can bill using CPT code 9601 and some remote therapeutic monitoring code that can be seamlessly integrated into their clinical care workflow. And we have a flexible pricing model. So the primary pathway will be the provider charge using reimbursement, and also we also have consumer subscription, and also we can offer research and pilot deployments with our clinical partners. So we have raised $370,000 non-dilutive funds from our generous sponsor NIA, A2, and AITC, and we'll do a seed round in Q3 this year. So this is a team, and we have supported by the wonderful advisors, and Reconnaissance is our vision, mobility lab in your shoes, and enabling healthy aging in every step. Thank you.
Thank you. Questions?
Can you briefly talk through,
Yeah.
if I'm using the product, how is it adjusting my physical behavior?
So yeah, right now the older adults need to go to a clinic and be eyeballed by the physician. And instead of visiting the clinic, we might be able to send a kit to the patients at home and then put on the sensors and wear in their daily life. And we can transmit the data remotely to the clinician. And they can just look at it in the clinic, like how they are actually walking in real life. And now give more like, you should adjust your gait, you should do more exercise, you should go to a gait lab. Well, we are the gait lab. So yeah, they just give better clinical decisions, interventions.
How long will the evaluation run for? So like how often will they have to wear it?
Well, so initially we started with stroke rehab, which usually takes like 6 months. So we might be able to provide like 6 months of longitudinal monitoring. But we envision this to be like a daily base, like a tool that can be constantly wear. Like it's not a specialized medical device. It's just a regular sports insole or walking insole that can be wear by the user like regularly, and it will be able to pick up early signs of like frailty, gait decline, and inform the stakeholders, the caretakers, the providers to take action early, like exercise more or eat more healthy.
And then just one more question.
Yeah.
There's been like smart canes, for example, right? That can assist with walking and kind of monitor fall detections. Like for seniors, right, that may be using assistance, right, to walk. Like how would this fit in there?
So yeah, we are not competing directly with the walking cane, with those kind of devices. We are basically like shrinking the entire complicated $250,000 gait analysis lab into a form factor of a wearable. And they basically, so it's really hard to go to a gait lab and get diagnosed, assessed. It's very accessible to a lot of patients. We are shrinking that service to enable, like give the clinicians more optionality to get more insight for gait data from daily life, not a short clinical visit.
I just have a quick question.
Yeah.
We use, in our OTPT world, the steady assessment is kind of like the gold standard of how we evaluate, and that includes, obviously gait. It also includes things like sit to stand. Is sit to stand also a measurable measurable
Yeah, there are
possibility?
definitely a lot of insults, like with simple sensor, we'll be able to do the kind of test, like, yep. Yeah, we can definitely integrate that into our system, but we want to take it further ahead, like beyond the simple test. Yeah, thank you.
All right, thank you very much.
The way you move is as unique as your genetic code. And what if I told you that you can sequence movement the same way that you sequence DNA? In genetics, you identify patterns and detect subtle changes that indicate disease. At Hominin, we're doing the same thing, but for how people move. We're sequencing human movement and building a personal AI model for every individual, using data from devices they already own. My name is Dr. Alexandra Hammerberg. I'm co-founder and CEO of Hominin. I'm also an anthro-engineer. That means I'm an anthropologist and an engineer, because human movement sequencing isn't just an engineering problem, it's a human challenge. Every step that you take is health data, and taken together, they create a unique movement signature. That signature changes when something is wrong, after surgery, at the onset of neurodegeneration, or with increased fall risk. But today, we don't measure this outside of the clinic. I'm sure you've heard about that already, past one. Today, over 57% of people over 50 own a wearable device. These devices are constantly collecting movement data, every step, every shift in balance. But almost all of that data goes unused or underutilized, because every platform today compares you against a population average. We don't. We train individualized models, learning how you move over time in your real-world environment. Healthcare today cannot see how people move between clinic visits. Assessment is subjective and based on self-reporting with occasional check-ins or relying on caregivers to self-report. With Hominin, it becomes objective, captured daily with devices people already own. Instead of a few data points per year, we create a longitudinal movement profile. And instead of detecting problems at the next appointment, we catch changes as they're about to happen. So that's the why. Now about the what. At the core of our platform is what we call a large movement model, or LMM. We take raw IMU and GPS data from devices like AirPods and iPhones and extract the underlying structure of how someone moves. We build a personal baseline that evolves over time, and we detect subtle deviations to that movement that are the earliest indicators of disease. We surface these as alerts for clinicians, patients, and platforms. And critically, our API plugs in directly into existing wearables, turning raw sensor data into personalized movement intelligence without requiring new hardware. So if you're building a wearable platform, we should talk. This is a deeply technical problem, and our team reflects this. As I said before, I'm a biomechanist and an anthro-engineer. I lead our clinical models and model development. My co-founder Marcus is our full-stack developer and a multi-time founder. My co-founder Brandon has business strategy experience and almost a decade of sales experience. And our head of data is an astrophysicist who studies exoplanets. He's translating his models to humans. We're combining physics, biomechanics, and machine learning to solve a fundamentally human problem. So where are we starting? We have two initial high-value applications. First, in musculoskeletal surgical recovery. We work with clinicians and patients to track return to functional movement after procedures like foot and ankle surgery. And second, orthopedic implant and device assessment. We work with device companies to quantify real-world functional outcomes outside of the clinic. Both of these use the same underlying movement intelligence layer, the same models, just a different distribution. We're a science-first company. We're backed by the NSF SBIR Phase 1 and the A2 Pilot Awards, as you can tell, because I'm here. We also have 2 completed IRB-approved studies at the University of Washington, where we've shown that we can use movement to identify individuals and that we can detect simulated pathologies in uncontrolled environments. We also have a patent pending. Our initial wedge is in surgical recovery, but our true power is in our infrastructure. We're building the back-end intelligence layer for movement across wearable platforms, clinical systems, and device companies, turning raw sensor data into something meaningful, personalized, and actionable. The way we move will define how well we live. In the future, we believe that every person will have a personal AI model, a model that grows and ages with you, a model that catches disease earlier, predicts injury and fall risk, and helps people live independently for longer, lowering the burden on caregivers. We believe movement will become one of the most important signals in health, and we're building the intelligence layer that makes it accessible. Thank you.
Thank you. Questions?
Very impressive. Can you very briefly explain how detecting through an iPhone or AirPods signals that actually are interpreting how I am moving and changing?
Yeah, so this is where the astrophysics comes in, so I won't get too technical, but basically we were able to take the movement signal and decompose it and add the context of the environment that it's in using the GPS metrics, and we're able to build a model around that. So we have these features that describe your movement as an individual, and that was our first study basically to say, are these telling us anything? Can we actually decode how somebody's walking in their environment? So we can take that and essentially then identify mutations in that code, so treating it like an ATGC pathway. So if you identify mutations, then you have an earlier indicator of disease, fall risk, et cetera.
Just a quick follow-up. How quickly do those signals go from a signal to an interpretation?
Yeah.
Or does it take, is it over time?
So our studies, basically, I'll just give you a brief description of our human subject side. We had people walk unconstrained around campus at University of Washington with class changes, et cetera, wearing the headphones and carrying the phone. And we had them walk first normally, and then they walk with an ankle brace, and then a knee brace, and then a back brace. And we're able, one, to re-identify individuals with great accuracy, and two, we can distinguish between normal and non-normal walking in those individuals. And the circuit is about 4 minutes. So we can get re-identification of individuals within 4 minutes of data.
Yeah, I really like how you sort of tied the innovation to that very practical use case of post-surgical. I'm wondering about your ambitions for the broader use cases. You know, people's changes in gait could happen because of, myriad things, right? Sight, hearing, things like that. Is there an ambition to, on a day-to-day, in the day-to-day, once you notice kind of that frog in the pot of boiling water, how do you then link that to those contributing factors? They may not be there right now, but is that part of the roadmap?
Yeah, absolutely. So in our opinion, more multimodal data, the better. We just started with movement and environment, because obviously if you're walking around San Francisco, it's way different than walking around DC, just by dint of incline-decline. So adding in health data and additional sensor data is absolutely on our roadmap. And it's just kind of finding integration partners and seeing what they prioritize, and then what the clinicians want to see from that as well.
Thank you.
Thank you.
My name is Sean Montgomery, and I want to talk to you today about one of the biggest problems facing America and the world at large. Alzheimer's disease devastates people's lives, and Cognitrend can help. Our solution leverages over a decade of experience using wearables to track behavior and physiology, and continuously monitors the range of functional impacts caused by Alzheimer's progressive neurodegeneration. Does anybody here know anybody with Alzheimer's? I'm here because I've seen it firsthand. And I can go on for hours about the neuroscience of Alzheimer's, but what that misses is the impact it has on people's lives. I watched my grandma lose herself to dementia and fracture our family in the process. I can count on one hand the number of times my mom has talked to her sister in the last decade. Fortunately, state-of-the-art has improved since my grandma passed, but the current diagnostics still have real challenges. Critically, it takes years to identify and track Alzheimer's progression. The good news is that new treatments are coming out, But we need an accessible way to identify problems early and track when treatments are working for the individual. Alzheimer's progressively damages the brain, beginning in areas that affect sleep, mood, and sympathetic balance, well before the known impacts on memory and executive function. Our team has helped Fortune 500 companies create biometric solutions for over a decade, and now we're leveraging our expertise to track cognitive decline. Cognitrend uses high-fidelity wearable sensors to passively monitor behavioral and physiological changes from daily life activities. And scientific evidence has shown that the latest advances in AI can utilize these signals to extract continuous metrics of cognitive health, track treatment effectiveness, and catch decline early on when treatment is most effective. The market opportunity for Alzheimer's is off the charts. With just 1.5% SAM, we estimate we can get to 120 million per year in the first 7 years. Cognitrend is based on a subscription model, initially targeting people diagnosed with MCI who want a cognitive wellness tool to track treatment effectiveness. Our early adopter strategy will leverage our partnerships with Johns Hopkins and the UC Davis Alzheimer's Disease Center to grow our user base, visibility, and data sets. As our data flywheel enhances our machine learning and IP, we plan to extrapolate to assist with early detection and explore partnerships for scalability. In parallel with our early adopter market, we'll be pursuing FDA and medical billing pathways to optimize scalability and numerous acquisition opportunities. We've been working on algorithms to extract cognitive and emotional metrics from wearable device data for over a decade. And we've recently received non-dilutive NIH funding to apply these technologies to Alzheimer's disease. Working with Johns Hopkins and UC Davis this year, we'll be further developing our IP to create significant advances. We have a rock star team to make Cognitrend a success. Our core team includes over 30 years industry experience that have helped launch numerous successful biometric sensing products. In addition, we've established partnerships with UC Davis Alzheimer's Disease Center, as well as geriatric, FDA, and billing experts to ensure we're structured for success from the beginning. We're not the only folks thinking about sensing-based approaches to Alzheimer's, but what differentiates us is high-fidelity wearable data that avoids garbage in, garbage out, and covers the range of downstream impacts created by Alzheimer's damage to the brain. Our financial roadmap puts us ramping revenue to 1.2 million by year 3 and reaching 4.8 million in sales by year 5. We're early stage, looking for ground floor investors who believe in us and our mission to bend the curve on Alzheimer's and accelerate first to market opportunity. Alzheimer's is ruining lives every day, and Cognitrend can help by providing continuous metrics of cognitive wellness to detect early and track treatment effectiveness. If you or anyone you know is interested to be part of the solution, please contact me.
Thank you. Questions?
Hi. Can you share more about who will be paying for this?
Sure. Our go-to-market strategy is individuals paying out of pocket. We're going to be leveraging our partnerships with the different research institutions and their Rolodex of patients and participants. And in parallel with that, we're going to be working on FDA, the changing landscape of the FDA, as well as medical billing pathways, so that down the road, there will be opportunities for real scalability.
And just to follow up, how do you kind of evaluate the pricing of the individuals?
We want to make it approachable. So that's one of our considerations going in. I don't know if our number right now of $40 a month is the number we'll end up with, but I think that's an approachable number that is much cheaper than a lot of things you could buy in your life. But it also, I think, would be enough revenue for us at the scale we're looking at approaching to continue to grow the company.
No questions? Thank you very much. So thank you very much. As the judges complete their scoring, we will next proceed for lunch. So I want to say two things. I was actually very impressed with the pitches. I listened to hundreds of pitches. This is a good group, right? Number one, I didn't have to cut anyone off. Number two, they were very practiced. So those of you who are in the room who are awardees, I hope that you were observing. You know, I mean, this is the way to pitch, right? Very direct, to the point. You know, very value forward. Lots, of course, the technologies are all there, but it's really part of the value story as opposed to simply just the technology. And this is, you know, the kind of difference that you see between, let's say, a research seminar and a pitch like that. And then very clear focus on the audience. Who are they trying to pitch to? Who are, you know, what are they trying to get out of basically the judges that are listening to them. So thank you very much. We will reconvene at 1:20. Lunch is outside on the first floor on the beach. And again, don't forget that we will be announcing the winners at 3:20, so please be back in this room. Certainly for very interesting sessions after lunch, but at 3:20. By the way, on the fourth floor are the demos. So those of you who did not get a chance to see the demos from the various awardees, some of them are super interesting. You can proceed to the fourth floor and talk to some of these pilot awardees on their projects. Thank you very much. Good job.